Well, welcome back. This is our second topic, our second pathophysiology topic. This is cardiovascular, and we're going to do it in two parts. Obviously, there's an awful lot more to it that we simply don't have the time to cover, and you will never remember for the exam anyway. So we're going to do two things. We're going to look at atherosclerosis, not only in terms of cardiac, but also the whole process of plaque formation, wherever that may be in the body, but with a specific focus, of course, on cardiac. In the second video for this, we will look at heart failure. So systolic, diastolic, left-sided, right-sided. But in this video here, we're going to follow our usual format. So the first part is about the underpinning pathophysiology. This is about the processes that cause the problem in the first place, the pathogenesis, if you like. In the second part, we'll look at the applied pathophysiology, and this is where we look at the signs and symptoms and how that underpinning pathology then feeds into the signs and symptoms and causes the signs and symptoms. And a lot of this topic really is going to be back to the sympathetic nervous system and it trying to compensate for problems. So before you start, maybe do some revision on that. So to start off, let's talk about ischemia. And as I intimated before, we aren't just talking about coronary arteries here. There's lots of arteries in other places that, if we have ischemia in that area, can cause significant problems, such as, of course, the brain, such as periphery. Ischemia really is an insufficient supply of blood to an organ, and this is usually due to a blocked artery. The arterial perfusion of the organ or tissue falls short of that organ or tissue's metabolic needs. We have a perfusion demand mismatch. So this is about a balance, really, between the amount of perfusion, the amount of blood that we can get to that tissue or organ around this blockage in the artery, versus the amount of demand that we put on that tissue or organ. The more demand we put, the more perfusion we need. But we're going to hit a bit of a plateau if we have an obstruction, when demand will exceed our ability to perfuse. So when tissue demands for oxygen, obviously in order to synthesize ATP, when those demands increase due to increased activity, we increase our activity, we need more ATP, we need more oxygen. The perfusion may not be adequate for that increased demand. At rest we still need significant amounts of ATP, but we need less ATP, therefore we need less oxygen. Therefore, the perfusion that we're able to achieve around this blockage may be enough that we don't have a problem. Where we're talking about this blockage, the narrowing or sometimes complete occlusion is often due to atherosclerotic plaques, or, especially in the case of a complete occlusion, we're talking about thrombosis, when that plaque then ruptures. So let's start talking about atherosclerosis. Atherosclerosis is the narrowing of the arterial lumen by plaques, atherosclerotic plaques, or atheroma. And the word comes from Greek, athero meaning gruel or porridge, And we'll see when we start to talk about how plaques form, what that's exactly referring to. Atherosclerosis. Sclerosis is hardening. And again, we'll see in a minute about how fibrous caps form, which can harden off the top of these plaques. Amazingly, it actually begins in childhood. It's a progressive process. It begins in childhood. It has the potential to cause ischemia in middle to older age. And the key word there is potential. And that's going to be dependent on various familial factors, so inherited factors, or lifestyle factors. In young children, the early lesions are called fatty streaks. And you can see there we've got yellow patches forming in the walls of the vessels. These fatty streaks and the eventual plaques often form where the blood is most turbulent, so at bifurcations, at branches in the vessels. And what's happening is the blood is flowing in, it's getting swirled around, and this is causing shear force on specific areas of the vessel wall. And this is where the plaques are most likely to form. In early adulthood, these fatty streaks start to turn into fibrous plaques. Stable atherosclerotic plaques can just sit there and be stable and cause a slight occlusion to the vessels. Hopefully that's what's happening in most of us. But, and we'll look at these mechanisms in a minute, they can become unstable. And this is when we start to get problems, real problems. Because when they become unstable, they rupture. When they rupture, we get a thrombus forming. That thrombus can then completely occlude the artery. Atherosclerotic plaques, this is where our gruel or porridge bit comes in, are mainly formed, at least in the center, of altered lipids. They're oxidized lipids. And also macrophages. Many of those macrophages have phagocytosed those altered lipids and are now full of this fat. They have become something called foam cells. And this all happens in the vessel walls. So our lipid enters, then some macrophages, the macrophages phagocytose the lipid, and we have this porridge-like plaque developing within the wall of the vessel. So let's talk about those contributory factors. So we were talking about children having fatty streaks that eventually turn to fibrous plaques. And we probably all have those, but we don't all have symptomatic disease from those. And this depends really on a combination of factors. So you can call it a multifactorial disease. And like a lot of the things we're going to talk about, there is an impact from both genetic factors and from environmental factors. In terms of genetic factors, along with lipid metabolism, it is quite a complex process. So you can understand there would be quite a lot of proteins involved in that. Those proteins have to be coded for by genes. So an individual gene mutation in anything that is used in lipid metabolism has the potential to cause a problem. So there are potentially a lot of mutations that could affect lipid metabolism, and that lipid metabolism could predispose a person to the formation of atherosclerotic plaques. We've also got to think about genetic mutations in terms of things that code, in terms of genes that code for coagulation factors and fibrinogen. And again, this is a complex cascade. So there is the potential for lots of different mutations having an impact on that. Genetic variation in RAS and nitric oxide synthase. Nitric oxide synthase produces nitric oxide. Nitric oxide, of course, is a key vasodilator. It's released locally to cause vasodilation if there is any obstruction. RAS, if we have genetic variation in RAS, we have the potential for hypertension. And hypertension could be a key factor. Think of that turbulent blood swirling around. It's going to be even more turbulent if it's at a high pressure. Infections, again, this is something that's going to crop up, particularly with autoimmune disorders, but with lots of other disorders. But often infections that we have in younger age can be seen to correlate with the development of later diseases. And this is obviously all going to be about how our immune response responded and what happened as a result of that. Remember, we always make memory cells. So if we develop memory cells to the wrong thing, then we are going to start attacking the wrong thing, which could cause later chronic disease. So viral and bacterial infections have been implicated, correlated with the evolution of atherosclerosis. Two particular ones are chlamydia and H. pylori. Autoimmune factors as well, again back to immunology here having an effect. So SLE, rheumatoid arthritis are all linked to atherosclerosis. And there are theories that autoantibodies may have been developed. This is what I was saying about the memory cells. Memory cells, the memory B cells, produce antibodies that will go off and opsonize our host proteins. We don't really want these to do that, but that's autoimmunity for you. Rheumatoid arthritis has another impact in that you tend to develop these big antibody complexes, these big nets of immunoglobulins, and they can often get lodged under the vessel, into the vessel walls, and will start off an irritation. So rheumatoid arthritis in particular tends to result in an increase in atherosclerotic plaque formation. Lifestyle factors, of course, and this is why we advise our patients, ideally if we can explain to them why we're nagging about these lifestyle factors, we can give them some simple pathology to think about, then hopefully it will encourage them to follow our advice a little more carefully. In this case, we have hyperlipidemia. So we have an increase in plasma LDL, the liver, lots of fats coming in. I need to make lots of LDL. So we increase the amount of LDL, hyperlipidemia. This increases the chance of subendothelial accumulation of LDL. Remember, we said the center of these plaques is full of altered lipid. That lipid comes from LDL. Also, apart from LDL, we end up straight after eating with a postprandial accumulation of triglycerides. Now, normally triglycerides are broken down. They're separated out. Triglycerides, you have a molecule of glycerol, you have 3 fatty acid chains. Lipoprotein lipase comes along and cleaves that glycerol off. We can then use glycerol and we can use the fatty acids to make ATP. If we have too many triglycerides and not enough lipoprotein lipase, those triglycerides won't get cleaved. If they're not cleaved, we can't use them for energy. So they contribute to the overall lipid profile, if you like. And an interesting factor here is that lipoprotein lipase, the enzyme that breaks down triglycerides, is actually increased by exercise. Even simple standing. They did a study on mice, tied some down, allowed some to stand up. And the mice that were allowed to stand up had a higher level of LPL, lipoprotein lipase. So they were better able to deal with triglycerides and convert them to something usable rather than a lipid going around our circulation. So exercise stimulates LPL production. Therefore, a lack of exercise reduces the ability to use triglycerides, and we get increased LDL production. So if we're telling a patient you need to increase your exercise, if we can give them a simple version of that, a simple reason why they need to, it will increase an enzyme that will break down your fats. They may be better encouraged to follow your advice and increase their exercise. And as I said, in a study on mice or rats, whatever it was, even simple standing increased LPL production. Smoking, overeating and obesity stimulate inflammation. If you have a large meal, you immediately have a low-grade acute inflammatory response. And often, you know how it feels. You have a great big meal, you eat more than you should, and you're an absolute couch potato. You feel awful. You don't feel very well at all, and you're starting to regret now overeating. That's because you're having an acute inflammatory response. In terms of obesity, we're talking about more long-term chronic inflammation, low-grade chronic inflammation. But a low-grade chronic inflammatory state is extremely damaging in many, many ways, including aging and frailty. Smoking also stimulates an inflammatory response. This is going to increase, apart from other things, the number of free radicals, like reactive oxygen species. Reactive oxygen species is going to play a key role in our plaque formation, as we'll find out. Reactive oxygen species, heads up, oxidizes LDL. Remember, we talked about altered lipids. This is the alteration. They become oxidized. And it's free radicals that oxidize LDL. And this makes it more atherosclerotic. On that note, let's talk about reactive oxygen species, or ROS. These are generally oxygen molecules that act as free radicals. They act in this way because they have unpaired valence shell electrons. This makes them reactive. If you remember, the valence shell on an atom is the last shell of electrons, the outermost one. In this shell, atoms like their electrons to be in pairs. And if they're not in pairs, they will seek to share another electron, so they will seek to bind to other molecules, other atoms, to try and share an electron so they've got a pair. So reactive oxygen species therefore readily binds to other molecules, and this can cause a multitude of reactions. And here you see we've just added 2 hydrogens to our O2, which has given us hydrogen peroxide, H2O2. Generally, ROS are naturally produced in small quantities in a controlled way during oxidative phosphorylation, and those can act as messengers. They're also found in lysosomes, and they help with the breakdown of phagocytosed targets alongside proteases, other enzymes, toxic chemicals. They can also be released, and when they're released they act as inflammatory mediators, so they can bind to various receptors and cause various reactions. However, an excess of ROS, if we have too many free radicals, this can cause oxidative stress in cells. And if a cell experiences oxidative stress to a sufficient level, it will trigger apoptosis. Apoptosis will then stimulate inflammation. So we will have a low-grade inflammation, not an acute massive one with lots of swelling and all the rest of it, but we will have some sort of inflammation going on. Free radicals like ROS also oxidize LDL, making it more atherosclerotic. So here, because of reactive oxygen species, we've got an increase in inflammation and we've got the oxidation of LDL. So another player in our little story are lipoproteins. We've just talked about LDL. LDL is a lipoprotein. And the role of lipoproteins is to transport lipids around the circulation. Obviously, lipids being lipids, they're hydrophobic. Therefore, they don't like the watery plasma. They have to be transported in these little packages called lipoproteins. Within the lipoprotein, you find cholesterol esters, that just means cholesterol bound to fatty acids, and triglycerides. Remember, we just talked about triglycerides. They're made up of a molecule of glycerol, 3 fatty acids, and our lipoprotein lipase cleave the 2 apart, known as lipolysis. Around the lipoproteins, we have a coat, and this coat is formed of phospholipid, unesterized cholesterol, and apolipoproteins. These are proteins that bind lipids. As we said, the lipoprotein structure enables hydrophobic lipids to be transported around in the watery plasma of the blood. We talk about density, LDL, low density lipoprotein. The density is determined by the number of proteins, that's the dense part, compared to the amount of lipid. So the lower the density, the greater the lipid content. Lipoprotein lipase, we've already talked briefly about, remember, catabolizes, it breaks down triglycerides. So we have our triglyceride with a glycerol molecule and 3 fatty acid chains. LPL cleaves that, separates the glycerol from the 3 fatty acid chains. And this is called lipolysis. This is what we refer to when we talk about lipolysis. And it's dependent, as we said before, on the availability of lipoprotein lipase. That's the thing that gets increased when we exercise. So therefore, when we exercise, we're better able to break down our triglycerides. It's also upregulated by the sympathetic nervous system and downregulated by insulin. And as we said before, both components of triglycerides, TGs, can be used by cells for cellular respiration separately. So glycerol enters cellular respiration at the glycolysis stage. Fatty acids, on the other hand, are much more efficient because they are converted to acetyl-CoA via a process known as beta oxidation to enter the Krebs cycle directly. So they miss out glycolysis. Very low density lipoprotein. Remember, the density is about the proportion of protein to lipid. So very low density lipoprotein has a lot of lipid compared to the amount of protein. This is synthesized by the liver. Of course, the liver takes everything that we ingest via the hepatic portal system from the GI tract, and then metabolizes it, processes it, packages, stores it. So what it does with lipids, it synthesizes and releases VLDL with its high proportion of lipid. Along comes our lipoprotein lipase, liberates the triglycerides for cellular respiration. So it liberates them and then it chops off the glycerol. Glycerol can go into glycolysis. The fatty acid chains can be converted to acetyl-CoA. By taking that lipid out, it converts VLDL to LDL, low density lipoprotein, because we've lost some lipid. So our proportion of protein to lipid is now higher in terms of protein. There are two types of LDL. It's slightly more complex than this, but this is the simplified version. What happens is pattern B tends to be smaller and denser than A. Because it's smaller and denser, this does tend to make it more atherosclerotic. So pattern B appears to be more atherosclerotic, probably because being smaller, it can pass through or between the endothelial cells into the walls of the vessels, into the intima, the tunica intima, much easier. High density lipoprotein, of course, here we've got much more protein than lipid, HDL. It's smaller and denser, but it's protective because what it does, it goes round and it binds free cholesterol and then returns it to the liver. So it cleans up any free cholesterol. Okay, quick revision on endothelium. I promise then we will start getting into a bit of how the plaques form. Endothelium. We did a little bit on it in physiology. And this is where we're really going to focus in terms of our atherosclerotic plaques, is the tunica intima. This is basically the endothelial layer, the layer of simple squamous epithelial cells, and the basement membrane. And there you can see our nice flat squamous endothelial cells, simple squamous, and our basement membrane. And then we have a little bit of a space, and that's our tunica intima. So it's the layer that's closest to the lumen, closest to the blood. Below that, we have the tunica media. And this is our layer of smooth muscle cells. Remember, our smooth muscle cells, they're little shapes that all fit together. They communicate via gap junctions, but they don't have sarcomeres. They contract in a different way. And below that, we have a layer of connective tissue. This is the tunica externa, is the connective tissue layer. Where we're going to focus now is really on the tunica intima, although our smooth muscle cells will have their part to play soon. So plaque development then. You remember we talked about turbulent blood. So we have these plaques developing at areas of turbulent blood at bifurcations where the blood's going round and round and round. And within that, we have our LDL. At areas of disturbed blood flow, that LDL gets pushed or passes between the endothelial cells and gets into the tunica intima. Within the intima, this is where our alteration comes in of the LDL. Within the intima, the LDL is then oxidized by ROS and other free radicals, and it becomes something called OX-LDL. OX-LDL are our altered lipids. OX-LDL then binds to scavenger receptors on tissue macrophages, and that stimulates phagocytosis. So basically, along comes our macrophage within the tissue, and it binds and phagocytoses the OX-LDL because it's an altered lipid. It's different, it's wrong, it's a target now because it's altered. And it phagocytoses it. So our macrophage that has phagocytosed OX-LDL will carry on phagocytosing OX-LDL as long as it is there. So the more LDL we have, the more phagocytosis, the more it is oxidized by free radicals. So in other words, the more free radicals we have, the more it will be altered and become phagocytosed. So macrophages, if they repeatedly phagocytose the OX-LDL, they become big, fatty, dysfunctional couch potatoes. They become laden with lipid, and this lipid makes them dysfunctional. At this point, they're known as foam cells. It's the foam cells and the OX-LDL that form the fatty streak in the vessel wall, in the intima. This fatty streak, so far, it's not grown enough that it protrudes into the artery or reduces the size of the lumen, so it doesn't occlude the artery at all. It's just that yellow fatty streak. But the problem is, if you remember from immunology, when a macrophage phagocytoses, it also releases a lot of inflammatory mediators. In addition, endothelial cells can also synthesize and release a lot of inflammatory mediators. They may be stimulated by the inflammatory mediators from the macrophages or by damage, whatever. But what we have is the release of large amounts of colony stimulating factors, cytokines, chemokines, prostaglandins, interleukins, all of those. Macrophage colony stimulating factor is particularly significant here. This, of course, will then stimulate, remember the sequence, leukocytosis. So they go off, our colony stimulating factors go off to the bone marrow, and stimulate the release of more white cells, more leukocytes. So we have neutrophils coming in, we have macrophages coming in, more macrophages. Vasoactive changes. Vasoactive changes, of course, part of that, remember it's vasodilation, but also increased vascular permeability. Those endothelial cells will shrink. When they shrink, it will make bigger gaps so that those white cells can get through in the process of emigration. Remember our monocyte coming in, and it starts to roll because of vasodilation. It gets stuck to cell adhesion molecules. It sticks a foot through diapedesis, then it wriggles all the way through. So the gaps facilitate more macrophages moving into the area that have been stimulated by leukocytosis. Chemotaxis, remember chemotaxis? This is where our cells that are there already, phagocytosing, are giving off chemokines. Those chemokines help to direct our white cells that are now coming in, our leukocytes that are now coming in, have been recruited to the right area. So we end up with the recruitment of more macrophages and dendritic cells into the intima, where we've already got this fatty streak. And of course, if they get there and there's some ox-LDL lying around, they'll start to phagocytose too. And if they phagocytose enough, they will also become these big lipid-laden, lazy foam cells that are totally dysfunctional. And you can see we're now starting to protrude a little bit into the lumen of the vessel. We're starting to develop more of a plaque. But of course, they also secrete more cytokines, which exacerbate the inflammatory response even more. So we'll have more leukocytosis, we'll have more emigration, more phagocytosis, and the whole thing will start to escalate as long as there is ox-LDL in the intima. As the plaque gets more full, the lumen of the artery becomes narrowed. So these big, lardy, fatty foam cells are totally dysfunctional and they basically need to die. And they can be stimulated to undergo that programmed cell death, apoptosis, by pathways that involve something binding extracellularly or by pathways within the cell itself. This is where we get to this issue of mitochondrial stress. And this isn't just foam cells. This can apply to any cell that is sent into apoptosis, that is told basically to go kill themselves. In the extrinsic pathway, the cells on their plasma membrane have death receptors. Death receptors are also known as Fas receptors, F small a small s, and that can then be written Fas-R. If ever you see a big R at the end of something, it usually means receptor. Binding to the Fas-R potentially is Fas ligand. Nice simple naming going on here. In other words, the ligand that binds to the Fas receptor, but it is a specific chemical, very closely related to TNF-alpha. So TNF-alpha can also bind to Fas receptors. And nitric oxide. Any of those binding to the Fas receptor will then stimulate this pathway within the cell that leads to apoptosis. And it does this by activating something called caspases. Ases, obviously, they're enzymes. There's a few more steps in it. That's the simplified version. but it involves activating these caspases. The intrinsic pathway, as we said before, this is about the mitochondria becoming stressed. They become stressed, they realise we can't really function, we're not getting enough oxygen, enough this, enough that, then we can't make ATP. This cell is no longer viable. So they become stressed due to this intracellular dysfunction. They also become stressed, as we said before, by the action of our old friend Ross, and by hypoxia, which is logical because, of course, if there's not oxygen for aerobic cellular respiration, then those mitochondria can't function. When they become stressed, they release cytochrome C, and they actually get this from those proton pumps. Remember, the proton pumps in the electron transport chain were made of cytochrome. So they use cytochrome C, and that then activates caspases again, causing apoptosis. So we've got a pathway within the cell involving mitochondrial stress and caspases. Then we've got this extrinsic pathway where something binds, Fas ligand, TNF-alpha, nitric oxide, and also stimulates caspases. Both of these stimulate apoptosis in the foam cell. As you may remember, apoptosis involves this process. It starts with DNA fragmentation, so the DNA starts to break down. Then the proteins within the cytoskeleton or within the nucleus start to degrade. They either degrade or they start binding to each other, this thing called protein cross-linking. Following on from that, ultimately what we get is the formation of those apoptotic bodies. So everything, if you remember, it goes through blebbing, where you get this wibbly-wobbly outer membrane. That membrane then closes in on itself, separates off, and we get these separate little packages wrapped in plasma membrane that are the apoptotic bodies. So at the end of this, we get apoptotic bodies, and we also get those expressing receptors for phagocytes. If you like, this is like a DAMP. Remember damage-associated molecular patterns? Now, normally, the apoptotic bodies would then bind to phagocytes using these receptors, be phagocytosed, and then cleared away. This normal process of clearing up apoptotic bodies is called efferocytosis. But in this case, remember all the adjacent macrophages are also couch potatoes. They've also eaten, phagocytosed, lots of lipid. They've turned into foam cells. They're dysfunctional. So they're not really up to doing a bit of efferocytosis. They're not up to clearing those apoptotic bodies. They'll sit at the other end of the sofa, if you like, going, no, I can't be bothered. So those apoptotic bodies don't get cleared away in this situation. Efferocytosis is ineffective. Eventually what happens, those apoptotic bodies, they don't have the machinery anymore to maintain them. So the proteins within them will degrade. When they degrade, the apoptotic bodies degrade. They start to fall apart. The plasma membrane wrapping them starts to break. They release their contents and they go into secondary necrosis. So although apoptosis is supposed to be a clean death, lovely, it is only if you've got macrophages to come along, phagocytose the apoptotic bodies. If you don't, the apoptotic bodies go into secondary necrosis, they degrade, and they release their contents, in this case, an awful lot of lipid. This released lipid, and also, of course, the foam cell debris, gives us this necrotic liquid core. And this is our gruel or porridge component, the athero part. This necrotic liquid core forms within the middle of the plaque. Because it's liquid, it makes the plaque unstable. Because it's unstable, it's going to be more prone to rupture and therefore thrombosis. But there are mechanisms that try and then stabilize this plaque. So one of these is we have fibroblasts. Whenever you have an inflammatory response, you will ultimately have fibroblasts because they secrete the matrix that the cells are going to proliferate into during repair. So fibroblasts, if you remember, secrete connective tissue, in other words, collagen. So the fibroblasts come up and they start secreting collagen within the top of the plaque, just under those endothelial cells. Also, the smooth muscle cells, I said they'd have a role to play eventually, start to proliferate. Now, if you remember, they're below the intima, they're in the tunica media, but they start to proliferate over the top of the plaque. So just under those endothelial cells, they grow up from the sides, come across and meet across the top of the plaque. And this is stimulated really by growth factors. So secreted growth factors, fibroblasts secrete fibroblast growth factor, strangely enough. There's also vascular endothelial growth factors. All of these growth factors bind and stimulate mitosis. They stimulate mitosis, in this case, of the smooth muscle cells. So the smooth muscle cells proliferate across the top of the cap in amongst all those fibroblasts that are secreting collagen. Our now stabilized plaque has a fibrous cap made up of collagen and smooth muscle cells. It can partially occlude the artery. If you remember, we recruited loads more macrophages, they gobbled up more LDL, so our plaque started to protrude into the lumen of the vessel. But we've now made a fibrous cap. So what we've got is narrowing, but this narrowing is now stable. It's less likely to rupture. We go back to our perfusion demand mismatch. Yes, this could very well be fine at rest, but if our man or lady with this occlusion, partial occlusion, goes out and digs a garden, there might not be enough perfusion to cope with that. So they may get a brief period of angina. The angina will then settle at rest because the demand then reduces to within the ability to perfuse the tissues. So as we said, depending on the level of occlusion, this will cause a perfusion demand mismatch. Obviously, the bigger the plaque gets, the less demand you can put on it. So tissue demands increase by stress or by physical activity, and that then causes a problem because you can't get enough perfusion to cope with that increased demand. Unstable angina, this is where we start to get a bit of a problem with our nice fibrous cap and stabilized plaque, because various factors can destabilize the plaque, making rupture more likely. So our nice fibrous cap that we made we can start to break it down. This happens because there may be apoptosis of smooth muscle cells. Our smooth muscle cells that grew over the top of the cap might start getting triggered, perhaps via TNF-alpha, nitric oxide, fast ligand, to go into apoptosis. Also, the endothelial cells may be affected. So we might start to get apoptosis. And bear in mind, if any dendritic cells, macrophages, manage to phagocytose OX-LDL, for example, and go off and activate an adaptive response, we could well have activated cytotoxic T cells. If they've been activated so that their antigen is something that's stuck to a smooth muscle cell, for example, then they will then attack that. So we've got apoptosis via FAST receptors or potentially activated cytotoxic T cells. There may also be breakdown of this collagen. Remember, our fibroblasts laying down all their lovely collagen. Fantastic. The problem is when you get any inflammation, any necrosis, any breakdown of cell content, you release proteases and other toxic lysosomal enzymes. Our key protease that often we talk about are the matrix metalloproteases. These MMPs are quite useful in wound healing because they break down the matrix that the fibroblasts have laid down to allow for cellular proliferation. However, if we've got too many of them, they can't be counteracted and they go a bit mad and they start breaking down things that they shouldn't be breaking down. So all this collagen our fibroblasts are laying down starts to get broken down by proteases and other enzymes. And much of this is going to come from that necrotic core in the middle. Another issue here is mechanical pressure. And we've got this from two directions, really. We've got that liquid core in the middle. If it's carrying on increasing, it's going to put pressure from inside, if you like, a bit like putting a bit more air into a balloon. It's going to make the walls of the balloon a bit more fragile. So we've got mechanical pressure from within, from the core, but also we've got outside mechanical pressure. If you think of blood flowing down the vessel, it's going to hit the shoulder of the plaque. That shear force could cause damage. Okay, so let's have a funky diagram. As we said, MMPs, other proteases, enzymes from the lysosomes, degrade the extracellular matrix and the collagen that the fibroblasts have laid down. In addition, we have fast ligands, TNF-alpha, nitric oxide, all binding potentially to fast receptors, FASRs, to stimulate apoptosis of the smooth muscle cells and the endothelial cells. In addition, we may have cytotoxic T cells. They bind and they stimulate apoptosis. If you remember, they bind via their T cell receptor. Once they do that, they release perforins and granzymes, and these trigger apoptosis. In addition, we have that mechanical pressure, both from within due to the build-up of a liquid core, but also because of blood flowing down the vessel and hitting the shoulder of the plaque. And this is often where plaques will rupture. And if you put into the mix here a little bit of hypertension, a little bit of vasoconstriction maybe because you've activated the sympathetic nervous system, then that shear force from the blood is going to increase. When the plaque does rupture, we have thrombosis. A thrombus forms at the point of rupture. In this case, we've got a small thrombus. This is causing a partial occlusion, but it has increased the occlusion of that vessel. It's taking up more of the vessel, so our ability to perfuse past it, if you like, has reduced. And this really is where we're starting to look at unstable angina. If the thrombus is big enough, we could have complete occlusion. In other words, we're going to have infarction beyond that point. The other issue is because we've got shear force from the blood, and remember it's hitting the shoulder anyway, and that's where we're likely to have this big thrombus. The thrombus may be dislodged by shear force, and then of course it moves on down the vessels until it gets to a finer capillary. In that finer capillary, it may completely occlude it. It'll just get stuck and it will occlude that capillary. Again, leading to infarction beyond it. Another issue here is vasospasm. This is going to potentially decrease the width of the lumen, the size of the lumen even more. And we get this because of vasoconstriction, but also inhibited vasodilation. In terms of vasoconstriction, those platelets that have aggregated, they start to secrete thromboxane A, also serotonin. Now, both of these cause smooth muscle contraction, and therefore they're going to cause vasoconstriction. Our other problem is that our dysfunctional endothelial cells potentially secrete less prostacyclin. If you remember, prostacyclin comes from arachidonic acid. They may secrete less nitric oxide. Endothelial cells use an enzyme, eNOS, endothelial nitric oxide synthase, to make nitric oxide. If they secrete less of it, there will be less nitric oxide. Now, both prostacyclin and nitric oxide are vasodilators. And nitric oxide is a really useful one in local areas where there's occlusion. So inhibiting it is quite a significant problem. And these two, this effect of vasoconstriction and inhibited vasodilation, give us vasospasm, which is going to reduce the perfusion even more by reducing the size of the lumen. And here you can see on our scanner here, we've got blockages of the common trunk of the left coronary artery. That's quite significant. We've got further blockages further down in a smaller artery, possibly because a thrombus got knocked off and has got lodged there. And you can see we've got occluded, we've got reduced perfusion at that point. Now, what we actually need is we need to have as long a period of angina attacks before we have our major MI as possible, because what happens is the body develops compensatory mechanisms. In one of those is ischemic preconditioning, and what happens is that the myocytes start to get used to having a degree of hypoxia. They become more efficient at using the oxygen and the ATP that they have. So they can cope with that reduced level of perfusion and therefore oxygen. This is ischemic preconditioning. So myocytes learn to function more efficiently and learn to protect the tissue from the effects of hypoxia. And they can do this for about 2 hours after an ischemic episode. And no one really knows quite how this works, but it is being investigated as a therapy to try and prevent, in particular, reperfusion injury. In the longer term, and this is where you have your person who has repeated angina attacks, what happens over a period of time is that the myocardium will start to stimulate angiogenesis. And this angiogenesis will basically grow a new blood supply. It will grow branches that join up. So if a particular area is constantly threatened by reduced perfusion, collateral blood vessels start to bud off and grow and bypass the occluded arteries. And you can see in the right hand there, we've got branches from 2 larger arteries have joined up in the middle. So if you occlude the one that's occluded in the first one, it doesn't really matter because you've actually got a supply coming in from another artery. These are collaterals. So that was our underpinning pathophysiology for atherosclerosis. That's how plaques form and how they can then become stable and then even become unstable and take us through varying degrees, really, of occlusion. Our applied pathophysiology is where we look at the signs and symptoms. So obviously, the first one we're going to talk about is going to be pain, cardiac chest pain, the old classic. Discomfort, tightness, and bear in mind, of course, not all patients have all of that, particularly women. Hypertension and tachycardia. I wonder what would stimulate that. Dyspnea, tachypnea, palpitations, arrhythmia, pallor, sweating, and nausea. Let's have a look at those one by one. So pain. Now, in terms of cardiac pain, in your pre-learning, you learnt about the difference between transduction and transmission and perception. In terms of transduction in cardiac pain, and we always start with transduction because, of course, it's an afferent, that's where it starts. In terms of transduction, both of the mechanisms are chemical. We have purinergic stimulation and we have something called acid sensing ion channels, ASICs. In purinergic stimulation, we're talking about adenosine and ATP. Now, most ATP, of course, is produced by aerobic cellular respiration. So if we've got reduced perfusion, we've got hypoxia, there's going to be a deficit of ATP. And if you remember, what we can then do is that we can hydrolyze ADP again. So we can do repeated hydrolysis. Eventually, okay, we'll ATP, we go down to ADP, we hydrolyze again, we get AMP, hydrolyze again, we get free adenosine. Cardiac myocytes actually use adenosine and ATP to try and protect themselves. So they release it, they exocytose adenosine and ATP. And what these do is they bind and they cause vasodilation. So they cause smooth muscle relaxation, vasodilating the area, which of course is going to increase perfusion and help to resolve the problem. When released, though, in terms of pain, remember we're talking about pain here, adenosine and ATP bind to purinergic receptors on sensory nerve endings. These receptors are G protein coupled receptors, our old friend the G protein. That G protein, activated alpha subunit, remember, opens sodium channels. When it opens sodium channels, sodium influxes, and we get an EPSP, excitatory postsynaptic potential. Which brings us on to our other receptors that are found on acid sensing ion channels. Now, in ischemia, glycolysis really has to sort of step up to the mark, if you like, because it's anaerobic. It's trying to compensate for the inability to do too much aerobic cellular respiration because perfusion is down. There's also an increase in fatty acid oxidation to try and fuel cellular respiration. This is more efficient. Alongside this comes a reduction in glucose oxidation. This is not only stimulated by hypoxia, but it is also stimulated by the sympathetic nervous system. As an upshot of this, what we end up getting is increased levels of lactate, a product of glycolysis in these circumstances, and an increase in H+. Both of these are released from the cardiomyocytes. When released, H+ binds to receptors on the A6. These A6 are channels found on sensory nerve endings. When H+ binds, they open. Now, these channels allow an influx of sodium, but also of calcium. So we get Na+ and Ca++ potentially influxing, creating again an EPSP. A6 are also sensitized and are much more likely to open, 80% more likely, when ATP binds to the purinergic receptors. And this is via that G protein. Remember, purinergic receptors are G protein coupled. And also, they're sensitized by lactate. So lactate binds to a second receptor on the ASIC, which helps to sensitize them. Other things can bind as well, such as neuropeptides. We'll talk about those later in the module. Arachidonic acid, you remember arachidonic acid, serotonin and nitric oxide. These can bind and sensitize the ASICs. Okay, which brings us on to transmission. Of course, all those EPSPs get summated at the trigger zone at just past the free nerve endings. If there are sufficient EPSPs, it will generate an action potential, which will then travel up the afferent sensory neuron. So the nerves that we're talking about carrying these neurons here are the cardiac sympathetic and to a lesser degree the vagus. Most of the pain pathway involves the cardiac sympathetic nerve. Both of these carry autonomic afferents and autonomic efferent neurons. Of course, in pain, transmission is via the afferent autonomic neurons. And this happens in all visceral, all organ pain. It travels via afferent autonomic neurons. And the pain pathway from there on is as per your preparatory reading. So, of course, our afferent goes into the dorsal horn, synapses with the second order crosses over, goes up the spinothalamic tract on the opposite side, contralateral side, to the thalamus, synapses again with a tertiary or third order afferent, which then travels up the internal capsule to the somatosensory cortex to be perceived as pain. But, and this happens in all the pain pathways really, there are many branches and synapses at different levels, particularly in terms of that second order afferent. It may branch off to various areas, and this causes different effects. In this case, the key one here is that it branches off and activates the sympathetic nervous system. Which brings us on to referred pain. So here you see our normal pain pathway. You can see we've got transmission from the myocardium. Up, we've got the soma of our afferent sensory neuron there in the dorsal root ganglion, into the dorsal horn, synapse for the second order afferent, which crosses over and ascends to the thalamus and then to the cortex. In referred pain, what's happening is you've got a second afferent, primary afferent, that shares a second order afferent. So you've got two of them sharing the same second order. In this case, we're talking about the left arm and shoulder. So that has sensory afferents. They feed in, same thing. They have their little soma in the dorsal root ganglion. They come into the dorsal horn, but they synapse with the same second order afferent. Obviously, by the time this gets up to the cortex doesn't know where that pain is coming from. And generally, it will assume that it's coming from the skin. So somatic pain rather than visceral pain. Hence, we get referred pain. Now, we also sometimes get jaw pain in cardiac chest pain. It's less common, and really there's no properly known mechanism. What is suspected though, if you remember, we had loads of little interneurons in the spinal cord. Generally, we talk about them communicating at one spinal nerve level, so communicating across the spinal cord, not up and down it. But it is now thought that they may have crosstalk, in other words, they may communicate or synapse with interneurons on a different spinal level. So this may be the reason we get this jaw pain. Most of our other signs and symptoms are going to be due to, or made worse by, the activation of the sympathetic nervous system. So why do we activate the sympathetic nervous system? Well, first of all, potentially, there's the baroreceptors. If you remember, we've got the baroreceptors in the arch of the aorta and in the carotids. If those mechanoreceptors detect that cardiac output and therefore blood pressure has dropped, then they will activate the sympathetic nervous system. Remember about the frequency of action potentials to our cardiac centers. Sympathetic nervous system is also activated by anxiety and the perception of pain. So the cortex can activate, it can release adrenaline, which will set off the sympathetic nervous system. And this is why when you're anxious, for whatever reason, perhaps an exam, then your heart rate goes up, you get sweaty. That's your sympathetic nervous system cutting in. We also have these functional connections. Remember, we talked about the second order afferents of the ascending pain pathway, branching off and activating the sympathetic nervous system. So pain can, if you like, physically activate the sympathetic nervous system through actual neurons branching off. They branch off to the medulla, activate the sympathetic nervous system. And if you think of, again, when you have severe pain, you're sweaty, your heart rate goes up, etc., etc., all signs that the sympathetic nervous system has been activated. And of course, the sympathetic nervous system then stimulates the secretion of noradrenaline and primarily adrenaline from the adrenal medulla. And this adds to this whole soup of catecholamines, adrenaline and noradrenaline, because of course sympathetic neurons exocytose noradrenaline. So we get rises in the levels of the catecholamines. So we get noradrenaline from the sympathetic efferent neurons, adrenaline from the adrenal medulla. They all bind, if you remember, adrenaline binds to the same receptors as noradrenaline. They all bind to adrenoreceptors throughout the body. Noradrenaline and adrenaline can also exacerbate myocardial damage. If you think about it, that's quite logical, because what they're going to do is ask the heart, ask the myocardium to do more work, to beat harder, to beat stronger. So they have the potential to increase that damage by doing so. And it's been seen that they can potentially stimulate necrosis even in non-ischemic myocytes. So here's our sympathetic nervous system in all its glory. So when it's activated, the pupils dilate. Salivation decreases, it becomes thicker. Respiratory rate increases. Remember, this is about fight or flight. So we're going to need to get more oxygen into our muscles. We're going to need to get rid of more carbon dioxide. And as we know, heart rate increases. Our pre-potential steepens, remember, affects the funny channels, sensitizes them. And also, there's an increase in the release of calcium to cardiomyocytes, so contractility increases, thus reducing end systolic volume, increasing stroke volume, increasing cardiac output. Alongside that, the peripheral vessels vasoconstrict. And in this way, of course, our peripheral resistance increases. So with heart rate and contractility, we increase cardiac output. Peripheral vessel vasoconstriction, we increase peripheral resistance. Both of these are components of blood pressure. So they both increase blood pressure. Adrenaline and noradrenaline are stimulated and they're released then from the adrenal medulla. Gastric motility, GI motility reduces. Glycogenolysis increases, which is sensible again. If we want fight or flight, we need more glucose released. So we break down our glycogen in the liver. And gastric secretion reduces. We also get sweating or diaphoresis. We also get piloerection. Remember that from fever. It was a mechanism of conserving heat. It's sympathetically activated, and it gives goosebumps. Okay, so let's start with dyspnea, tachypnea. They're slightly different things, really. Dyspnea is the subjective awareness of breathing difficulty, and this can be physiologically stimulated or it can be psychologically stimulated. Tachypnea, of course, is this quantifiable, this measurable increase in respiratory rate. Mechanisms contributing to this, they're quite complex, so we'll try and simplify it a little bit. First of all, we have the awareness of muscular respiratory effort. We're always aware when you're putting a lot of effort in with your muscles. And the same with respiratory muscles. And that's detected by mechanoreceptors in the chest wall. So we become aware that we are putting more effort into breathing. The chemoreceptors, we could have them activated if pulmonary perfusion is reduced or gaseous exchange is reduced. Pulmonary perfusion may be reduced because cardiac output is down. Gaseous exchange might be reduced if we have something like pulmonary edema starting. So we can activate the chemoreceptors due to increasing PCO2, that's the prime driver, remember, via the monitoring of H+, or in hypoxia if it's severe. If you activate the chemoreceptors, they will activate the sympathetic nervous system, increase respiratory rate. So as we said, pulmonary perfusion may be reduced by right-sided coronary ischemia, so that our cardiac output into the pulmonary circulation is reduced, or by myocardial stunning. Myocardial stunning is the situation where the myocardium basically goes on strike for a little while out of shock. Pulmonary edema, we mentioned, we may get this if there's a left-sided ischemia, because what's happening is the heart isn't pushing the cardiac output onto the systemic circulation, so we get backward pressure. We'll talk more about this when we talk about heart failure, because it's a common problem with left-sided failure. So that might happen if the left side is affected, and of course pulmonary edema is going to put fluid into the alveoli and reduce gaseous exchange. And as we said, if you activate the sympathetic nervous system, it will also independently contribute to increased respiratory rate. Now, J receptors. J receptors are found next to the alveolar capillaries, and they're activated by congestion. They're sensory cells located within the alveolar septa next to the pulmonary capillaries. You might see them described as pulmonary C-fiber receptors. And later we'll be talking about C-fiber cough receptors, but they're much higher up. These are the ones that are right down in the parenchyma of the lungs. They used to, I suspect they're the same ones that used to be thought of as silent cough receptors. So discovering them as being J receptors is fairly new. So what do? They're activated by the engorgement of the pulmonary capillaries. So if there's any inability to push the blood through into the systemic circulation, there will be back pressure into the pulmonary capillaries. They become engorged. The left side of the heart can't move the returning pulmonary circulation through quickly enough. They're also activated by increased pulmonary interstitial fluid. So if you have this engorgement in these capillaries, it will increase the hydrostatic pressure within those capillaries. As a result of that, you get transudation. You get fluid leaking through out of the capillaries into the tissues and potentially into the alveoli to give you pulmonary edema. And J receptors are now thought to produce the sensation or the perception of dyspnea. They make the person, when they're activated, aware that they have breathing difficulties, that there's a problem. A lot of this is about the balance of the awareness of difficulty and the ability to compensate for that problem. It's a very fine balance. There's quite a few articles on it if you want to read up on it. Hypertension and tachycardia, well, we know why that happens. And you can see I'm reminding you that blood pressure is cardiac output times peripheral resistance. Cardiac output is stroke volume times heart rate. Stroke volume is end diastolic volume minus end systolic volume. So we have, these are obviously sympathetic effects. So we have an effect on the prepotential. This is our chronotropic effect. So the sympathetic nervous system sensitizes the funny channels. Our prepotential gets steeper, therefore that draws together the cardiac cycles. It draws together the heartbeats. We also have a sympathetic effect on contractility, as we said. This is our inotropic effect, where we stimulate the release of extra calcium into the cardiomyocytes, so they contract more. This is the strength of contraction. Remember, this is nothing to do with recoil and Frank Starling. This is the strength of contraction that will help to reduce end systolic volume. If you reduce end systolic volume, you increase stroke volume. And vasoconstriction. Vasoconstriction, again, sympathetically activated. Noradrenaline binds to alpha-1 adrenoreceptors in this case and causes the contraction of smooth muscle cells around the vessels. This will give us increased peripheral resistance. As we can see, we've increased cardiac output and increased peripheral resistance. Therefore, blood pressure goes up. Along with that, we have an increase in heart rate. Eventually, we will activate RAS, and RAS will give us this increased blood volume. Remember, it takes a little while for RAS to kick in. This baroreceptor is generally much quicker, but RAS will cut in because we'll have reduced glomerular filtration. Juxtaglomerular cells will detect that, secrete renin, and off we go. We end up with angiotensin II, aldosterone, ADH. That will increase blood volume and preload. Palpitations. Palpitations, again, is a little bit about perception. And you can perceive it even though there isn't actually any altered rhythm or tachycardia. And they tend to correlate with high levels of catecholamines, in other words, noradrenaline and adrenaline. But the mechanism isn't really understood. Obviously, arrhythmia, we can see arrhythmias, we can demonstrate arrhythmias. These can also occur due to the sympathetic nervous system inducing tachycardia, disruption of the intrinsic pathway potentially, if we've got an area of infarction or stunning, or areas of reduced contractility due to ischemia. Pale and clammy. What a classic in terms of a cardiac presentation. Sweating, we said that the posh word is diaphoresis. The sympathetic nervous system, if you remember, tends to cause peripheral vasoconstriction. What it's trying to do is divert blood to more important organs and more important tissues to preserve those vital functions. So the skin, perfusing the skin is less important. Less perfusion, then we get less of that nice pink colour and we get pallor. The sympathetic nervous system also causes sweating. Remember our nice diagram from before. And possibly this is to reduce heat. So you're ready to run away or fight someone. Nausea. Nausea is a strange one in so many conditions because there are so many different vomiting centres that it's with different receptors for different things. It's quite a complex thing to explain in some circumstances. But the vomiting centre is located in the medulla. And if you remember, our pain pathways have direct functional connections. In other words, that second order branches off to the medulla, and it is believed it branches to the vomiting centre. And if you think about it, if you've ever had a severe acute pain, you do feel a little bit sick. In addition to that, remember we've got this effect of the sympathetic nervous system on slowing up GI motility, because in a fight or flight situation that's less important. So we could get a reduced emptying. In that reduced motility, we get distension. Distension stimulates vomiting receptors within the GI tract that are mechanoreceptors. They then send action potentials via vagal afferents up to the vomiting centers. And remember, it's not all about acute coronary syndromes. We can have plaques all over the place. If we have them in the leg, we can have intermittent claudication. So this is ischemic pain in the skeletal muscle of the legs. And it's a symptom of peripheral artery disease. It's a bit like having angina in your leg. Again, we have a supply-demand mismatch. So if you do lots of walking or activity with your legs, then you might get pain because perfusion can't feed that demand. So you get pain in the leg on walking a certain distance, which often resolves on rest. It's that classic, I walk to the shop for the paper, and just when I get to the shops, I get a pain in my leg, I have to sit on the bench and it goes away. Another issue would be the pain would get worse if the legs were elevated, because of course that reduces the perfusion due to gravity, and that's going to be a bit like putting more demand on. And this is where this idea comes from, that people with intermittent claudication want to sleep with their legs hanging out of the bed because gravity is assisting with perfusion. Of course, this can progress. It can progress to distal gangrene. So here we're talking about really our MI equivalent. If that collateral circulation is not adequate. But again, we can have angiogenesis, we can develop collaterals to feed those tissues if it's a long-term progressive condition. If not, we end up with nice black toes. Okay, so that was the end of atherosclerosis. Again, there is a handout separate for this one if you want the text version of the video. Make your own notes and diagrams. After every topic or every week, learn the topic material. Remember the techniques that we used in physiology and use those, including using a study buddy to teach them. If you find that this all isn't making much sense because you can't remember the physiology, please go back and revise your physiology first. And yep, don't delay because there's still plenty more to learn.